Dear colleagues, welcome to the Virtual World Conference on LH 2020. You have been invited by media to this exciting journey into the new galaxy. I think it's a good opportunity to update our knowledge on the specific role of LH. When I had a look at PubMed in the search of publication related to LH, I found more than 60,000 publications, with the first published by Science in 1941. The title of this article was Regarding FSH and LH, and the objective of the author, named Albrighton, was to find out new names for FSH and LH. Interestingly, the author suggested gametotrophic hormone for FSH and sex hormone generator for LH. Therefore, I can better understand why the main message delivered during my medical education by professors, namely men, was that LH has a beneficial effect on male sexual behavior and performance. Regarding ovarian function, the stimulatory effect of LH on estradiol and androgen is well known, but the issue of progesterone is still an enigmatic subject. Therefore, I invite you right now to participate in this exciting journey, flying through the stars of endocrinology. The topic of my presentation today is the progesterone rise. Should we consider that it is a black hole of control ovarian stimulation? A black hole, what does that mean for scientists? It is usually defined as a region in space where the force of gravity is so strong that nothing, not even light, can escape from it. The translation for gynecology could be the following: a situation associated with a high risk of poor cycle outcome and from which it cannot escape. In the specific issue of the excessive premature increase in serum progesterone, should we consider that it is really a black hole? Hopefully no, and the purpose of my talk is to convince you that it can be prevented. We know that the premature rise of LH is not really a luteinization because the plasma level of LH is always low after the introduction of GnRH analogs. The incidence of progesterone rise is not well known, but there is a large consensus to say that there is a decrease of pregnancy rate by about 10% if progesterone is higher than 1.5 or 1.75 nanogram per ml. The preliminary results regarding the pregnancy rate if progesterone is higher than published by Ernesto Bosch. It was a study involving more than 4,000 cycles, and you may observe on the slide that there is a sharp decrease in pregnancy rate if progesterone threshold is higher than 1.5. In the same time, Wang and collaborators showed that the duration of serum progesterone elevation should be considered with a decrease when it is more than 1 day. In the same time, other publications show that the transfer of cryopreserved embryos could restore a high pregnancy rate. And you can see on the slide the green line with a high pregnancy rate after transfer of frozen embryos as compared with the fresh embryos. This data suggested that progesterone rise could affect the ability of the endometrium to implant. the same time, to confirm this hypothesis of endometrium inability, it has been published some data regarding the inadequate expression of genes involved in implantation. But you should be aware that if you use a natural cycle for the transfer of frozen embryos, you can have similar reduction in clinical pregnancy if plasma progesterone is more than 1.59 nanogram 2 or 3 days before the LH surge. Therefore, you should be aware that even if you transfer embryos, frozen embryos, the risk of low pregnancy rate could be observed in natural cycle with a premature rise of progesterone. Data illustrated that high progesterone level on the day of trigger is likely to advance the implantation window. And I would like to show you this picture. You may observe that in the follicular phase, there is expression of progesterone receptors, and after triggering of ovulation, progesterone increase, and the window of implantation is open, and the embryo can implant. In the case of premature rise of progesterone, you may observe that the window of implantation will be open prematurely, and the transfer will be obtained and performed out of time. This asynchrony between embryo development and the ability of the endometrium to implant can explain the low pregnancy rate in this case. Another important issue regarding the rise of progesterone is to determine the progesterone threshold. We know that we should consider several factors. What kind of progesterone assay do you use? At what time do you perform the blood sampling? And should we consider the duration of progesterone rise and the patient's profile according to the intensity of the ovarian response? Progesterone assay, it is absolutely clear that a huge dispersion of results between techniques can be observed when progesterone is in the low range, as it is usual during the follicular phase. In this part of the slide, you can observe the coefficient of variation. It's the intra-assay variability. You may observe that within the low range of progesterone, the coefficient of variation is higher than 40%. Additionally, if you look at the inter-assay variation and you take the same blood sampling and measure progesterone with 4 different assays, the variability is between 1.3 to 2.1. This may explain that you need to assess your own range of variability for the assay you use. So another variability in serum progesterone level is linked to the time of blood sampling. You know that there is some diurnal circadian variation in serum progesterone during the daytime, and if you observe the slide, it is clear that between 8 a.m. and 8 p.m., there is a decline of about 44%. Therefore, it has been shown that 70% of patients with level of progesterone higher than 1.5 at 8 a.m. could display a progesterone lower than 1.5 at 8 p.m. Therefore, it is usually recommended to measure progesterone at 8 a.m. So another important factors you should consider when you want to determine the threshold is the patient profile and the intensity of the ovarian response. In this retrospective study, of more than 4,000 people, you may observe that the value of progesterone over which the pregnancy rate decrease is different in the different group of responders. In poor responders, it's about, the threshold is more than 1.5. In normal responders, it is more than 2.25. And in high responder, it is more than 2.5 nanogram per ml. Another study shows that if you consider the threshold of 1.5, it is clear that progesterone pregnancy rate is reduced only in poor and normal responders, but in hyper responders, there is no difference in the pregnancy rate. So what is the reason for that? To try to explain the impact of the ovarian response, you should consider the ratio between progesterone and the number of follicles higher than 14 millimeter. This index, named progesterone to follicular index, is quite interesting. Why? If you consider the picture on the right, you may observe that when the PFI is low, it means that the increase in progesterone is related to the number of follicles. It's a high responders and the PFI is low. In this case, the pregnancy rate is normal and you can transfer the embryos. In contrast, if the PFI is high, it indicates that the production of progesterone per follicle is excessive. It means that the steroidogenesis in this patient is really bad, and it is usually the case in poor responders. When the PFI is high, you may observe that the pregnancy rate is reduced. So you have to postpone the transfer of this embryo and try to implant them in a cycle, natural cycle with frozen embryos. So to conclude on that issue, we may conclude that a late follicular increase in serum progesterone is detrimental only if it results from the increase of progesterone secretion per follicle, but not if it results from the recruitment of a large number of follicles. In the second part of this presentation, I would like to discuss and stress the role of the FSH dose you use. It is well known that the increase in serum progesterone is well correlated to the intensity of the stimulation as shown as assessed by estradiol, the number of follicles, the number of oocytes. And if you look at this multivariate analysis of factors related to progesterone elevation, it is clear that the total dose of FSH is an important factor. And we try to understand why. A long time ago, it has been shown that FSH and LH can stimulate the production of progesterone in granular cells. In these two pictures, PCO patients and normal patients, you may observe the stimulatory effect of HCG and FSH, and you may also observe the close relation with the dosage of FSH and LH. So there is clear evidence that in unstimulated granular cell, LH and FSH stimulate progesterone in a dose-dependent manner. More recently, it has been shown that FSH stimulates several enzymes involved in progesterone production. You may observe the 3-beta dehydrogenase, and it is important to observe also that FSH stimulates the production of its own receptor. So FSH stimulates the production of progesterone, and it is absolutely clear that it is a dose-dependent effect. So on the granular cell, pregnenolone is transformed in progesterone, stimulated by FSH. Therefore, the higher the dose of FSH you use, the stronger the risk of progesterone rise. If you look at the effect of LH, it's totally different. LH can act only in the early follicular phase on sicker cell. And what is the role of LH? Is to transform the progesterone moving from granular cell to sicker cell, to transform the progesterone to 17-hydroxyprogesterone. But another important action of FSH on granular cells is to stimulate the expression of LH receptors. You can see on this slide that during the maturation of the follicle from the small antral to a pre-ovulatory stages, the expression of LH receptors sharply increase, while the expression of FSH receptor sharply decrease. So it means that under the influence of FSH, granular cells express LH receptors and become sensitive to LH. So if you look at the respective role of FSH and LH in the late follicular phase, you may observe that FSH and LH act synergistically to stimulate the 3-beta dehydrogenase to produce progesterone. Then progesterone moves to the sicker cell and can be metabolized to 17-hydroxyprogesterone by LH. So the effect in this part of the cycle, the effect of LH is a balanced action to stimulate progesterone production, and secondly, to metabolize progesterone to 17-hydroxyprogesterone. So it may be confusing because what is the real effect of LH on the progesterone secretion? If you look at the data published in clinical practice, the conclusions are very confusing. Two studies compare HMG and recombinant FSH on the issue of progesterone rise. In the MERIT study, you may observe that progesterone seems to be higher with recombinant FSH as compared with HMG. But you should consider at the same time the number of oocytes, which is significantly higher in recombinant FSH product, meaning that the increase of progesterone is probably linked to the number of oocytes and to the intensity of the response. In the megaset study, no difference in progesterone secretion between HMG and recombinant FSH was observed, even if the number of follicles was higher with recombinant FSH. So, according to this data, we may say that there is a slight and sporadic increase in serum progesterone when you use recombinant FSH, but it can be easily explained by the higher intensity of the ovarian response and not by an effect of LH to reduce progesterone. And it is clear that from that study, the effect of LH activity on progesterone synthesis is the opposite. Indeed, the study by Twensen nicely demonstrated that if you administrate from day one of the stimulation 50 IU 100 and 150 IU of progesterone, of LH or HCG, you may observe a dose-dependent increase of serum progesterone. So it is absolutely evident today that the consequence of LH is to increase progesterone in a dose-dependent manner. So the consequences of LH activity on progesterone synthesis can be explained by the effect of LH on CQ cell. LH can activate several enzymes which convert cholesterol to pregnenolone and pregnenolone to progesterone. This activation needs the 3-beta dehydrogenase, which is active only one way. At the stage of progesterone, 17-alpha hydroxylase can convert progesterone to 17-hydroxyprogesterone. But the influence of LH is not effective on 17-alpha liase in humans because this enzyme is not effective in human species. So 17-hydroxyprogesterone cannot be converted to androgen. The accumulation of 17-hydroxyprogesterone and progesterone cannot be reversed to pregnenolone because the 3-beta dehydrogenase is only one way. So it means that the secretion of androgen need to bypass the delta 4 pathway and to use the delta 5 pathway to produce androgen via the DHEA. We can say that in accordance with Eddie Anderson, who suggested the following conclusion. Progesterone secretion is mainly stimulated by LH-like products. However, FSH plays a fundamental role in the expression of LH receptors. It is proposed then that follicles with inappropriate high LH receptor expression due to high FSH exposure will whisper response. And additionally, HCG bolus trigger induce a very high progesterone in the early luteal phase, and it is responsible for the advancement of the window implantation. So this picture illustrates the primary role of FSH, which is the main driver of progesterone secretion. Indeed, FSH stimulates the expression of LH receptors on granulosa cell, and granulosa cells become hypersensitive to LH, with two consequences: high production of progesterone in late follicular phase, and secondly, if you trigger with HCG or GnRH agonist, you induce a high production of progesterone in early luteal phase. So these two effects explain why the asynchrony between embryo and endometrium is increased and can explain the reduced pregnancy rate. So the question is, how to prevent progesterone rise? According to what we have shown previously, it is clear that you should adjust the starting dose of FSH and use no more than 150 IU for normal responders, no more than 100 IU for hyper responders, and no more than 300 IU for poor responders. The second option is to use a step-down approach in case of hyper response with a beginning of progesterone rise. In this case, the reduction of FSH can help you to avoid a sharp increase of progesterone rise. And finally, the last message is clearly that you shouldn't use LH activity product in the final part of the stimulation because the risk of progesterone rise is enhanced. So we have many option to try to prevent progesterone rise with this adjustment in your dose of FSH mainly. And it is the reason why I believe that the issue of progesterone rise is not actually the reason to say that it is a black hole, because you can prevent this event. If you are not able to prevent this excessive rise in progesterone, it has been suggested to trigger ovulation earlier when follicle reaches the diameter of 15 to 16. But the main and the most popular option is the segmentation of the cycle. You trigger with a GnRH agonist or HCG, you retrieve the oocyte, and you freeze the whole cohort of oocyte and embryos with a subsequent transfer of oocyte and embryos in unstimulated cycle. It is usually what is done in many clinics in the world to prevent and to restore a good pregnancy rate. And finally, I am sure that you can prevent, and prevention is the most important aspect of our clinical practice. And I am sure that these babies will congratulate you for your skill to have avoided a premature rise of progesterone and to have avoided the freezer. I thank you for your attention.